Hello, everyone, and welcome to another episode of OncoDaily. Today, I have two special guests with me, and we're going to talk about a new way of approaching cancer. Throughout the years, we had the surgery, radiation, chemotherapy, and in the last 10, 15 years, we have immunotherapy. But today, we're going to talk about a new modality of approaching cancer and killing cancer cells in the body with very minimal side effects. And for that, I do have very special guests with me, Dr. Pasche and Dr. Shields. Welcome, everyone. Thank you so much for being here today.
Good to be here. Thank you.
Dr. Pasche joined the Barbara Ann Karmanos Cancer Institute in August 2023. He is the president and the CEO. He is a principal investigator of the National Cancer Institute Comprehensive Cancer Center Core Grant and the chair of the Department of Oncology at Wayne State University School of Medicine. His clinical specialties and expertise lies in treating gastrointestinal malignancies and hereditary cancers. His research focuses on cancer susceptibility and new therapies. In 2000, he co-invented a medical device. It's the TheraBionic P1. In 2023, this device was approved by the FDA to treat advanced hepatocellular carcinoma, or in simple terms, liver cancer, which is one of the most common types of liver cancer. Dr. Shields, he is also a professor of medicine and oncology at Wayne State University School of Medicine. He is also the Associate Center Director of Clinical Sciences at Barbara Ann Karmanos Cancer Institute. His clinical work focuses on the treatment of patients with gastrointestinal malignancies with an emphasis on colorectal and pancreatic cancer. He has more than 30 years of experience and research in imaging and drug discovery and development. He provides a clinical perspective and education on the use of new treatment agents for cancer patients. His lab developed a new PET tracer, which has been used in national studies to monitor patients with breast cancer. Welcome both to the show. Thank you so much for being here today.
Yeah.
I want to start by talking about this innovative device that we have here. How did this idea of treating cancer with radiofrequency electromagnetic fields come about? Can you tell me a bit more about this story?
Happy to. So this work started really in the 80s when a colleague of mine, Alexandre Barbeau, a Frenchman, and I started to work on patient with insomnia.
Okay.
And we had used a small device that was similar to this one that emitted 27 megahertz, which is a carrier frequency. And we were modulating this carrier frequency at a single frequency that was 42.7 hertz. That had been found more or less serendipitously, and we started to investigate patient to see whether we could see a parameters that would change with different frequency. So examining a large number of patients with chronic insomnia, we found that there were changes in pulse pressure, which is really a measurable pulse at certain frequencies. What we found is that 4 frequencies were found most commonly in patients with insomnia. And then we hypothesized, could we use these 4 frequencies to treat insomnia? First, we had one study with a single frequency, and it failed, did not show any benefit. Then we thought maybe we need more than one frequency. And what we found when we combined these 4 frequencies, we were able to demonstrate an improvement in sleep in patients using polysomnogram, which is an objective way to assess sleep quality. So that was the start of the investigation of patient discovery of frequencies. In 2000, as I was finishing my training as an oncologist, I had this wild idea. Could we use that for treating cancer? Could we identify frequencies that are specific to cancers? And we started this work in the early 2000s with my friend and colleague Barbeau. And within the first 2 years, what we thought is that we were finding frequencies that were very specific for tumor types, not for a given patient. So let's say we had 3 different patients with breast cancer. We found consistently the same changes at the same frequencies.
So it was more cancer specific.
It was cancer-specific. What we found is that if we had a liver cancer patient, the frequencies were totally different. We may have an overlap of 1 or 2 frequencies, but the majority of frequencies were different. So that told us 2 things. First, that patient reacted to frequencies with changes in pulse pressure. In other words, a pulse that was more intense and measurable for numerous beats, up to 30 beats. And second, that these frequencies were specific for tumor types, but they did not depend on the ethnic status of patient. We had patient with various ethnic status, with patient of various age and various gender, and we found consistently the same frequencies. So that gave us the first glimpse at what we call now tumor-specific frequencies. Gotcha. Having discovered these frequencies, we then designed a feasibility study to see whether this hypothesis could be tested. And to our surprise, of the 28 patients we treated first, we had several patients that responded to the therapy.
Were these all like breast cancer patients?
No, they were all comers. So we had breast cancer, we had pancreatic cancer, we had liver cancer, we had prostate cancer. Probably the most impressive first response was a woman with breast cancer who had failed 3 lines of hormonal therapy as well as chemotherapy. She was in a lot of pain, with bone metastasis in the left femoral bone and a large metastasis in the right adrenal gland. To our surprise, within 2 weeks of treatment, the pain was gone, and within 2 months, the tumor had melted away, and that lasted 11 months. She was not taking any other therapy.
So we're talking about really advanced, like resistant cancers here.
We have focused really on the examination of patients who had failed other therapy.
Okay. So, after these feasibility studies, like what happened next? How did we end up? Where are we today?
What happened next? One of my colleagues from Sloan Kettering had moved back to his native country of Brazil and was at that time leading the research arm of a large hospital that was conducting studies in the largest liver transplant program in Brazil, in Sao Paulo. So he asked me, he said, could we do a study in patients with liver cancer? So what we did, we traveled to Brazil and examined a large number of patients to make sure we had good frequency for that disease. And then we designed a study that was phase 1, phase 2, where we tested the hypothesis that it could work in liver cancer. And to our surprise, it did work. We had, on the first part of the study, several patients responded with tumor shrinkage, which is quite rare even with drugs in this disease. And some patients had stable disease for longer than 6 months, many more than we had predicted would have that. And that led us to continue the study to complete a phase 1, phase 2 study that demonstrated the feasibility of this approach as well as the impact it could have on patients with liver cancer.
I love it. Let's say I'm an oncologist listening to this, and these are very, very impressive numbers and cancers we're talking about. How does this device work? Like, what is the underlying? When we go to medical school, the only things we get taught about is like surgery, radiation, and the drugs. But this is completely new. How does this work?
So that's an excellent question, and it is really a reversed paradigm. We did not start in the lab. We started in patients, identifying these findings in patients, then treating the patients, and later on, we tested the hypothesis, can we identify how it works in cell lines, in xenograft? And that's what we did. While I was at the University of Alabama at Birmingham, one student came one day, right after the publication of our first paper, knocked at my door and said, Dr. Pasche, I would like to study this. And I explained to her that we did not have any funding, that it was, entirely novel. She said, I would like to do this. So we worked closely with the Department of Radiation Oncology, a doctor by the name of Dr. Brezovich, when worked before on the hyperthermia. And he said we could actually replicate these exposure by using brass plates connected to the device. No, that's what we did. It was
Is this the metal part here?
that's the coaxial device. So essentially, this device was connected. It's cut there, and it was connected to brass plate. One connection to one brass plate, the other to the other brass plate. So these brass plates were placed in an incubator, and we put cell line in this incubator. And the first test was, does it work? So we used a common tumor cell line that was actually created here in Detroit at Karmanos, the MCF7 cell line for Michigan Cancer Foundation number 7, which is probably one of the most widely used cell line in the world for breast cancer study. And what we did was to expose Petri dishes with these frequencies and compare with no exposure. And I will always remember the phone call I received from this graduate student, Dr. Jackie Zimmerman, calling me one day, and I was in a cab driving from O'Hare Airport to ASCO, and she said, "Dr. Pasche, it works."
That was the time of the discovery.
That was the time of the discovery. I said, "What do you mean it works?" He said, "The frequencies block the growth of the MCF7 cell line." And I said, "How many times have you repeated the experiment?" She said, 5 times. And suddenly I said, so it was working. So of course, when I returned, we looked at all the data, and there was indeed a significant inhibition of the cell proliferation of these cells. So that was the first time that we could show that these frequencies were actually blocking directly the growth of tumor cells. That was the first step. Second step was to use other frequencies. So we used the liver cancer frequencies, and we used dummy frequencies. And dummy frequencies were frequencies that were selected in the same range, but frequency we had never, ever observed in patients with cancer. They were at least 1 or 2 hertz away from a good frequency. So we predicted that these frequencies would not do anything, and that was a very good control because the cell line were all exposed to the same level of radiofrequency electromagnetic fields. What we found that the dummy frequency didn't work on breast cancer cell line, didn't work on liver cancer cell line. We found also that the breast cancer frequency did not work on liver cancer cell line, and the liver cancer frequency, while working well on liver cancer, did not work on breast cancer. So we were suddenly seeing in the lab a demonstration of the specificity of these frequencies. So each cancer has its own set of frequencies. And that was the first important step to understand the mechanism. The next step was to see, well, can we replicate that in animal model of human tumors? And we use what's called xenograft. We use cell lines or tumors obtained at the time of surgery, transplanted into a mouse, and then we expose the mice to the same level of radiofrequency electromagnetic fields. To do that, we worked with the Swiss Federal Institute of Technology in Zurich that built a custom-made exposure system that allowed us to replicate exactly the same level of exposure that the patient were receiving.
So it's like a human tissue in the lab, is that?
Human tissue in a mouse, and then you expose these mice to the frequencies or to dummy frequencies. We confirmed in these mice that when we expose these mice to the proper frequencies, for example, liver cancer frequency, liver cancer tumor, we saw a significant shrinkage of the tumor. So that allowed us to examine under the microscope what is happening with these tumors, because we had not rebiopsied patients that were receiving treatment, which are quite dangerous because they have already weak liver and the risk of infection and bleeding. So under the microscope, what we found is that the tumors that were exposed to the proper frequency indeed shrank quite a lot. And the tumors that were exposed to the dummy frequencies or no exposure did grow. There were several key characteristics that the pathologist highlighted. The tumors that were exposed to the proper frequency did shrink, and we saw inside the tumor a little lighter area at the center of the tumor. So we wondered what it was. It looks more like fibroblast. So it was looked like scar tissue. So we analyzed these cells. We sliced, of course, the tumors, worked very closely with pathologists, and came to the conclusion that actually these were cells that were quite different. We didn't know whether they came from the mouth, from the human tumor. So what we did was to repeat these experiments by tagging the tumor cells. We have some tags in in biology we can use called GFP, which stands for green fluorescent protein, so you can follow cells and see where they come from. And what we found is that these tag was following into the fibroblast. So we demonstrated that actually these frequencies could transform tumor cells, liver cancer cells, into scar tissue, and that it was happening inside the tumor as the tumor was shrinking.
So are we talking about like more differentiation or necrosis?
Differentiation, not necrosis. We did not see necrosis, but we saw that the tumor was shrinking, and these fibroblasts were probably then eliminated as the tumor shrank.
So, yeah. Very cool. So, and that was mainly, it was not related to liver cancers.
It was related to liver cancer.
Liver cancer.
Purely liver cancer.
Purely liver cancer. So at that stage, you are figuring out like how the drug works and which cancer respond the best and which frequencies are best for each cancer.
That is correct. Then the next question was, well, how do these tumor cells sense these frequencies, and how does it trigger these profound effect of tumor shrinkage and transformation of the tumor cells into fibroblasts? So through the work of Dr. Jimenez, who is a faculty here at Karmanos, we looked at images from these cells that were exposed to the proper frequency. What we found is that calcium was moving inside the cells. So that gave us a clue that it was probably a calcium-mediated mechanism. So through a lot of work, we looked at all known calcium channels and found through a systematic work that the CAV 3.2 T-type calcium channel, also called CACNA1H, was the sole receptor for these frequencies. If we remove this receptor, or if we block this receptor with a drug, like ethosuximide, which specifically blocked this T-type calcium channel, the effect was gone. So the cells did not respond anymore to these frequencies.
So that's when you started gaining understanding of the underlying mechanism.
That is correct. So this CACNA1H, what is very surprising and in a way made sense, is an important modulator of vascular tone. So essentially it allows to dilate or contract vessels. So suddenly we were finding a link between our identification of frequencies with change in pulse pressure and the tumors that were far away from where we were measuring the frequencies, but nonetheless had a receptor that sensed these frequencies and activated a response.
And that brings me, now I'm thinking about it, I think we have lots of treatments that focus on the vessels, like vascular growth factor receptors inhibitor or other drugs. So before talking more about hepatocellular cancer specifically, is there a link between these drugs and the mechanism of the device, or these two are not linked? The inhibitors and the
I would say there could be. We don't know yet. We don't know yet. And we have not seen, once again, necrosis, as you were talking about. We've seen differentiation. What we've also seen, and this is an article that was published just a few weeks ago, is that in 3 different tumor types, glioblastoma, breast cancer, and liver cancer, it's always the same receptor that senses these frequencies. The frequencies are very different. So different frequencies come to the same receptor and they activate different pathways. So the current hypothesis is that this calcium is really a signal and must probably pulse signal that's trigger activation of pathways that are different in different tumor types.
Gotcha. Now, I want to switch gears a bit. So we're talking about the device, and it's very fascinating to understand the mechanism. But I want to hear from maybe Dr. Shields. You can tell us hepatocellular cancer in general, the liver cancer. Where do we stand today? What are the available treatments?
Well, we've certainly made a lot of progress in the last decade. I mean, the standard treatment, certainly if it's small, is to cut it out, freeze it, radiate it, and those work. But unfortunately, most of the patients we see at the time of diagnosis have more widespread disease. It takes over a good portion of the liver, or it's spread outside of the liver. Until the last few years, we had really very limited options there. We now have some targeted therapies, some drugs that attack the pathways for the vasculature that have activity and have been licensed, and there are 2 or 3 of those that we regularly use. And then over the last few years, we found that immunotherapy works, and there are a number of immunotherapy drugs that are actually used either alone or in combination. Sometimes those results are dramatic, particularly with immunotherapy, but even then it's a minority of our patients. And the approval of those drugs is in patients with good liver function. We divide people into sort of classifications. We call them Childs A, B, and C.
Mm-hmm.
And A have to have good liver function. And those drugs are all approved for Childs A. So we often see patients coming in who have more advanced disease, or they have bad livers due to cirrhosis, certainly one of the causes of liver cancer. So we have lots of patients that either not candidates to begin with for these treatments, or have received them and may have gotten some benefit or may not, but they generally progress over time, and then we're sort of left without other options.
Where do we stand today when it comes to the TheraBionic device? Where are we trying it or trialing it here in Karmanos? And let's say I'm a patient, I'm hearing about this. Can you take me through the steps, how this device is going to cure my cancer?
Well, cure is
or control. Let's say control. That's
control and hopefully shrink. Well, first of all, as you heard, it was FDA approved about 2 years ago, and it was approved by Medicare for payments a year ago. So it can be used as part of that label. And it's only for that disease right now that it's approved. And we've started, I think we did the first patient in the country under that proviso on November 1st last year.
Oh, so we started recruiting November 1st last year.
For treatment.
Okay.
We now have opened a protocol to gather further data as requested by the FDA. And it's for a wide range of patients with liver cancer, primary liver cancer. They don't have to have Child's A. They can have basically near liver failure. We want people that we expect are going to live for a time, but the requirements don't specify what their liver function looks like. They can be in pain. They can have poor performance status. So we offer it to a wide range of patients to collect more and more data on them and the efficacy of the device.
So I think that's one of the points I really want to emphasize here, because when it comes to liver cancer, only patients who usually are doing well before their treatment are eligible for clinical trials, and those are the Child-Pugh A class. But there is a big population of the patients with liver cancer who are like Child-Pugh B, Child-Pugh C. We can't offer them treatment, and that device is now a new way of helping to control the disease in that specific population that was previously excluded from clinical trials.
That's right. So the protocol, for instance, we have now says these patients have to have failed a couple lines of therapy or been ineligible for them because their liver is not in the best of shape to begin with. And so they really don't qualify under standard protocols to get the immunotherapy or the targeted drugs.
And I think that's an important point too, because in general, I think an oncologist or a patient who are listening to this, when we thought like Child-Pugh B, Child-Pugh C, the first thing come to their mind is like, okay, so we don't have treatment options. Clinical trials will exclude them. But here we're talking about no, we do have a clinical trial that include patients with worse liver disease, which is fascinating. But I want to switch gears a bit more. So we're talking about liver cancer. Why not other cancers? Or are we going to?
Well, actually, as Dr. Pasche mentioned, they've done it in a number of other cancers in a limited number of patients. And this included breast cancer. It has included thyroid cancer. They had some brain tumors and prostate cancer. And we are opening and have opened clinical trials for a number of other cancer types. And some are already open now. And we have a number that are in the process of being opened or planned.
And does the same thing apply? I'm just thinking from a patient perspective, or if an oncologist who's listening to this episode, does the same thing apply for other cancers when it comes to those sicker people who are excluded from treatment? Would they be eligible, or is that specific?
It varies by trial.
It varies much.
One of the first trials we opened in the last couple of years was one for pancreatic cancer, and it's actually for first-line pancreatic cancer. There are a couple regular treatment regimens we use, They have been shown to improve survival, but the benefits have been somewhat limited, unfortunately, in pancreatic cancer. It's a very difficult disease to treat. So we have one trial that's open right now. We just signed up our 10th patient here. Other patients have been signed up at Wake Forest. And this combines the standard chemotherapy regimen of gemcitabine and nab-paclitaxel with the TheraBionic device. So we're combining standard chemotherapy with the TheraBionic as an addition.
Gotcha. Sorry, were you going to add?
We have other studies that are using the TheraBionic device alone, some that are combining it with chemotherapy or targeted agents as well.
Let's say I'm an oncologist, I'm listening to this, and one of the questions comes to my mind, and then I want to show the device here. So this is the spoon, and this is the device, how it looks like. So let's say I'm listening to this, and like, what should I tell my patients? Like, how do I counsel them about, there is this clinical trial in Karmanos running. How would you teach another oncologist to talk to their patient about this device? What should they tell their patients about this?
Well, as I said, these are, aside from liver cancer where it's FDA approved, they're all under research studies. And of course, under research studies, there are different groups of patients. As I said, some of the trials are just using the device alone. Others are in combination with other drugs or chemotherapy. So the patient I saw yesterday, for instance, has advanced liver cancer. They previously failed and had progression on FOLFIRINOX, a standard agent, which they received prior to surgery, and now their tumors come back. So the standard agent we would give them off study is that combination of gemcitabine and nab-paclitaxel. So I went over, and the patient came here saying, I want something new. I want a research study. And I said, well, and others had offered him that standard regimen. And I said, well, we can give you the standard regimen, but we will add this device to it. And he was really excited. We went over the consent form, and the additional, one thing that has not been mentioned by Dr. Pasche is the toxicity of this device.
Oh, yeah, let's talk about it.
Which is really minimal. And the FDA guidance on what the toxicity is, I've never seen before. It says the patients may experience fatigue. Well, this is all patients with advanced cancer, which I don't know if I've ever seen anybody without.
Exactly, yes, in general. It's very hard symptom.
That's how. And the only other one is the spoon has to go in your mouth basically 1 hour, 3 times a day, and you can get some irritation.
So that's the schedule.
That was really the only significant and not very severe side effect that's reported by this. So it's the side effect profile is really minimal. And obviously, we're always looking to combine drugs, combine different treatments. And one of the things we always look at is what is the side effect profile when I add drug A to B? Well, this really doesn't cause any additional side effects when I'm giving a standard chemotherapy regimen.
From patient perspective, so it is the spoon here. They have to put it on their tongue.
Right.
And how many hours per day for liver cancer?
Actually, for all the cancers, it's 1 hour sessions. And the device has 2 buttons from I see. It's got an on-off button, and it's got a start.
Yeah, it's pretty straightforward.
It's really pretty easy.
Yes, exactly.
And you turn it on, and you press start, and it runs for an hour.
Okay.
And it knows that it's in your mouth because it measures the conductance. It knows if you sort of fell asleep and it dropped out of your mouth, it'll stop running. And it'll basically times the hour. And when the patient uses the device, we have them bring it in to each clinic visit, and we turn it on. The device keeps track of how many hours they've used. So I know exactly, did they use it for the specified amount of time? Did they miss here or there? But the device traces track.
So we can track patients' compliance.
Yeah. The study we just opened, we usually, when we give patient a drug to take home, we give them a journal and say, did you take it?
Yeah, exactly.
When they come back, we count the pills. With this, I just say you bring the device in. And we turn it on, and it tells you how many hours have been used. It's really very simple.
That is amazing. So right now, I'm very, very excited when it comes to cancer treatment with this device. But I do wonder, how about other utilities of this new technology, other than cancer treatment? Do you think there might be other uses?
we have focused exclusively on cancer. As I pointed out, the initial work was done on insomnia. That was really more than 20 years ago. I would say one of the potential use of this technology is screening for cancer. Oh. We know, for example, that liver cancer occurs more frequently in patients who have cirrhosis or who have chronic hepatitis B or hepatitis C that damages the liver and makes transformation into cancer more likely. Given the fact that we can measure objectively changes in pulse pressure in patients who have cancer, we have actually already designed and conducted a study that is not being published yet, only in abstract form, where it appears we could screen patient at risk, let's say, for breast cancer or liver cancer, using these frequencies emitted just for 10 minutes and measuring the changes in pulse pressure. So I'm thinking this is something that could potentially be used in other tumor types, such as pancreatic cancer, where we really don't have any screening. For breast, we know we have excellent imaging, so that may not be the best type of tumor. But for liver, given the fact that they are a large part of the population, a large fraction of the population worldwide that are at risk for liver cancer, that may be an inexpensive way and non-invasive way to screen patients that may need more testing to find out whether they truly have cancer or not.
This is very exciting. I think, and also like there is a demand from people, like always, especially like right now, there are so many movement about like living longer, living healthier, and people want to know earlier if they have cancer or not, and they want to treat it early. So I think that would be a very promising way of detecting cancer early, given the current situations. Like we have very expensive tests that are not available for the general average person with an average income, and like we have insurance coverage and all these details, but I think that would be really a new way of approaching cancer. It's very, very exciting. And since we are recording right now this in Karmanos Cancer Institute in downtown Detroit, Michigan, I want to talk more about our institution here. So we're doing clinical trials, of course, not only for this device, TheraBionic, but we do lots of clinical trials. What makes Karmanos in general, or is specifically Karmanos, really unique when it comes to clinical trials?
Well, we've run lots and lots of clinical trials for years. Over the last several years, we've probably had about 700 different clinical trials.
Wow.
We're always looking for new drugs and treatments. Some of them are national studies run by the NCI. Some are done with drug companies who have exciting new agents that we're testing. And a number of the ones, like the ones we're doing with TheraBionic, are written by my colleagues here and are being tested here. We have many multidisciplinary teams that specialize in different tumor types, but they also have specialized clinical trials for each of those teams. And we have a very strong phase 1 unit. These are the very earliest trials. Sometimes they're drugs that have never been in human beings yet. They look good in the mice, and now we're moving them into people. Sometimes they're new drugs that are in combination with old drugs or combinations of old drugs that we're testing to see, are they safe, and then are they efficacious? So we're always looking for new drugs. Every week we hear about new studies, and we look to set them up, and we can do it rapidly here. Generally within 3 or 4 months, we can get new trials open, so we have those options for our patients.
I completely agree. I think one of the things I always feel blessed about and feel so lucky about is being trained in this institution. And over the last 3-4 years, I've seen things that I don't think I would have seen anywhere else. I've seen people with different cancers live longer, live better, and get better care. And all through this by interaction with my colleagues or the other oncologists who are offering these clinical trials. But what about the oncologists in general who work in the community or outside of Karmanos? How they can be part of this, or how they can refer their patients to available for clinical trials here, and how they can get notified about the clinical trials that are running here?
Well, the clinical trials, you can look them up at our website. Clinicaltrials.gov has basically clinical trials across the country, and our trials are all required to be listed there. And we have an app on our phone. It's KCI Trials.
Oh, so someone can download the app.
Yeah, you can download the app. and you can put in some parameters like, pancreas cancer or breast cancer, and you can see a list of the trials that are open. I'm going to say I use it regularly because we've got lots of trials open. And this way I can look and say, okay, which are my trials, which are open right now for a particular tumor type. It has some of the basic requirements of the trials. It's open to the public, although it's
patients can download that.
Patients can use it. It's not really written for patients. It's written for healthcare professionals, but patients will look at it and get information as well. And of course, we have patients coming in on their own or referred by physicians because they know we have new clinical trials. We know we have options not available other places. And so the patients come to us for a second opinion or a first opinion to sort of go, what do you have? Like my patient yesterday, he's specifically looking for a clinical trial. He called us to see what options we had besides the usual treatment, and we offer him the study.
I love it. Dr. Pasche and Dr. Schultz, thank you so much for taking the time and talking about this device. This is really exciting. I think it's a great time to be an oncologist, and it's a great privilege and a blessing to treat people with cancer and help them through that very difficult part of their life. And I think just being part of this and seeing how we have new ways beyond traditional ways of treating cancer being used and trialed here in Karmanos, it's such a privilege. Thank you so much for being here today. I really appreciate your time.
My pleasure. Our pleasure.
Thank you, everyone, for listening. Cancer doesn't sleep a day, as well as OncoDaily. We work every day to beat cancer. Thank you so much.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.